So I'm very excited to be able to be a part of this panel today. This is a really interesting group of folks, and what we want to do is spend some time having a conversation about where they're coming from, what they've seen in the industry. Some folks on the panel haven't been around as long as I have to see just that growth and development from the days where we were working in a clinic or a physician's office with the piles of paper, times in which I worked for a health plan, which I won't name, that I would go to the doctor's clinic and take their medical records out of the building and bring them home to my house to put them on my coffee table and do audits. I know anyone with security background cringing right now? Yeah, I see you here in headache. But that was all allowed because there's no other way to do it. Trying to determine quality of care by pouring through handwritten piles of paper in a clinician's office was the norm back in the day. So here we are 30 years later and really wondering how far we've come. Some would say not as far as we should, but the panelists today I think are going to share with you their thoughts about what we're seeing, some of the trends, some of the challenges, and what we can do to get over that next hurdle to utilize the technology that's available through electronic health records and other mobile devices and other means to really start to improve quality of care for patients that we're treating. So Aisha, I'm going to kick it off and have you start and give us a little background, and then folks will be asking questions and having a conversation as soon as everyone's had a chance to tell you a little bit about what they're doing. So keep your questions in mind and we'll call on you in just a few minutes. So Aisha?
Thank you, Lori. Hi, everyone. Good to see you all here. So today, we're going to be talking about QI initiatives in healthcare. I represent the Community Clinic Association of LA County, and as a part of the association, we have a membership of 58 clinics, and we also have 14 affiliates. So the affiliates range from like MedPoint management to like children's organizations, and most of our members are actual clinics that have multiple sites. We represent about 1.4 million patients. So for us in our network of our association, with 58 clinics, it gets really challenging when it comes to QI because all of those 58 clinics have their own leadership and they make their own decisions on what electronic health record they decide to go for. So as a network, when we are trying to provide services like QI initiatives or help with their electronic health record, it gets very challenging when they have multiple EHRs. So in our association, we have 20 of the 58 clinics are on NextGen. 20 are on eClinicalWorks. We have 6 on Epic, and out of the 6, 5 are a part of OCHIN. And then we have 12 other clinics that have one-off EHRs. And so some of those one-off EHRs are Allscripts, GE Centricity, Icon, MacPractice, some that, they aren't as widespread. So as an association, when we provide our services, they're like an umbrella service for all of the clinics. So we have tried to implement some QI data tools into the clinics. And that was a few years ago, and it was interesting because during that time, a lot of the clinics were upgrading their EHRs for the 2014 standards for MU, and so they weren't interested in collecting data. They were just interested in updating their EHRs. And so when we helped implement some tools in the clinics, what happened is when we checked in with them like a few months later, a lot of them hadn't even accessed their QI tool. Some of them didn't even know they had it. Other ones, they had so much staff turnover, and so those who retrained to use the QI tools weren't even there any longer. So that was just the beginning of us realizing this is not going to be an easy task to accomplish. So as we continue to work on QI efforts with the clinics, one thing that I felt the clinics weren't necessarily grasping was the importance of how accurate your data is. So, a lot of clinics I feel right now are healthcare organizations are using these tools, implementing these tools, and they're barely getting used to the idea of having these new tools. And there's like an excitement that comes with that, where you see, okay, wow, there's all this data that I can pull, and I can now create these reports that tell me, where I might not be performing well. But it's really easy to pull that report and start using that data. It's really important to go back and validate that data. So if that data is not validated, what ends up happening is you have a clinic that makes decisions on inaccurate data, and that can be very dangerous. So what I found to be a really good process for clinics or any organization when it comes to QI is validating that data. When you have a report, you need to go back and check and see where that data is being documented. And the documentation begins with the physicians. So, before you begin to use any tool you have with QI or use any data that you're pulling in your reports, you need to go back and make sure that the data is collected in the right place. On the back end of any kind of QI tool, there's a lot of mapping that goes on. And so if there's anything, with so many different sites and clinics using one tool, you need to start from the very beginning with the physicians and make sure that the workflow that they are implementing is consistent among all your sites or among all your organizations. So that way, when you're pulling a report per organization, you're comparing apples to apples, not apples and oranges. So that's something that's really important. And in order to even pull the data, it's very important to have the QI staff. A lot of the nonprofit organizations, like our clinics, they don't even have the funding to hire the staff to pull these reports. And so it gets really tough because the QI coordinator, for example, is usually the title. When they pull that report, it needs to be information that's communicated back to the leadership, because those decisions that are being made are business decisions. And what happens right now is a lot of the QI staff is pulling those reports and not sharing it with the rest of the clinic. They'll just pull what they're told by the leadership, but sometimes it's really important to keep that communication going for, like, if you're having monthly staff meetings, for example, to bring those reports into those meetings and communicate it to the staff. And something that Lori and I talked about was how it takes a village to really validate that data and to make sure that the data is accurate. So it's something that takes QI staff, physicians, leadership. It takes everyone in the clinic to really make sure that data is correct before it's being used. Thank you.
So good morning. I'm Zan Calhoun. I'm with Healthcare Partners. Just a smidge of background. Healthcare Partners has about 1,100 or 1,200 employed physicians. We operate in California, Arizona, Nevada, New Mexico, Colorado, Florida, Georgia, and soon Washington. And as you can imagine, having 1,100 or 1,200 type A personalities that want to tell me how our electronic medical record system should work, you get a little bit sort of sensitive to feedback and how you create something that physicians like. So let me spend a few minutes just kind of talking about my view of where the electronic medical record world is going, and then ultimately how that sort of impacts some of the quality reporting. First of all, how many of you went to college? Raise your hand. And how many of you went to graduate school? Raise your hand. And now, those of you that went to graduate school, how many of you took secretarial training while you were in graduate school? Okay. Because that's the biggest gripe that physicians have about electronic medical records, is what I hear almost every single day from one of my closest 1,100 friends in the world, is I didn't go to medical school to be a secretary, and you're underutilizing my talent, and you're taking time away from me being with my patients. So the welling up of dislike, distrust, animosity, discomfort with electronic medical records, and then you wonder why the reporting that's coming out of that data might be suspect, is not a particularly hard chain to put together. So let's just talk for a second about my belief in terms of where electronic medical records are going to go, and then talk about what that means in terms of of reporting. So I call this the V5 theory, and I cheat a smidge to make it be 5 Vs, so just bear with me. So the first item is what I'm calling viral. And what I mean by that is data is and will be coming in from an immense number of sources. Some of you probably already have an Apple Watch. You know, Samsung and others are already in that space. And we've got to assume that we're going to have medical records that are accumulating data 24/7, 365 from all types of sources. That may be good, that may be bad, but that's not how electronic medical records are set up today. Number two, you're going to see a significant incorporation of video communication. Whether we like it or not, we live in a video generation. People would much rather hear and interact than try to read or create the written word. So we're going to see communication coming in, or communication going back and forth in ways that are going to force us to look at new types of technology in terms of how we accumulate and ultimately aggregate and parse data. Number three, I believe that electronic medical records are going to be largely vocal, as opposed to having physicians sitting at a keyboard or NPs or PAs or MAs. It's going to be vocal. How many of you use Siri today? I use it regularly. I use it all the time. I can't imagine not having something like that, and yet we have hundreds of thousands of physicians that are unable to incorporate that type of existing working technology into medical records today. So we've got viral, video, and vocal. Those are the first three. The fourth one, I think, is, it's a little bit of a stretch, but I like it, and I've got a captive audience, so you're going to have to go along with me. The fourth one I call virtual, and what I mean by that is simply that more data is not better data. When I go in to see my PCP with an upper respiratory infection, he or she really doesn't care about my broken leg from 3 years ago. Unless, of course, I've had a history of broken bones, in which case there might be some link to osteoporosis or some other problem that may have to be diagnosed or taken care of. But an incidental broken bone is of no interest whatsoever to PCP treating me for a URI. Conversely, I go in to see my orthopod because I've got a broken hand. For those of you that follow the Clippers, there was, Blake Griffin broke his hand hitting an equipment manager, apparently. That was a little bit out of the ordinary. But I go see my orthopod, and he or she doesn't really care about my upper respiratory infection. So the ability to organize data in a fashion virtually so that it relates to either my history with that physician or what my presenting problem is, my presenting condition is, when I see that physician sort of gets labeled as virtual. And the last one, and this is where I cheat, I call it inviting. And what I mean by that is when you look at most electronic medical records today, oh my God, they overwhelm you under the theory of how much data can we get on one screen. And it's not inviting. The people that are GUI designers, have a fit dealing with it. But it's not easy, it's not inviting for the physicians or for others to use. So in my world, we will see significant advances using existing technology to make electronic medical records way simpler, way easier, way more meaningful for physicians. So what does that mean from a quality measurement standpoint, a quality tracking standpoint? My view is that electronic medical records will be self-policing or self-correcting. And what I mean by that is that when a physician is done vocally interacting with the electronic medical record, think of something like Siri, he or she is going to say, I'm done with this patient. And the system is going to say, you have 3 activities that you need to do to conclude this visit. You need to document this, you need to post this, you need to hit the enter key to do the update, whatever the activities are, but the system is in fact going to be reminding you of the things that you need to do so that A, the visit can be appropriately closed, but more importantly, that transaction can now be logged in a place where the downstream reporting can occur. In addition to that, I believe at the end of the day, physicians will be prompted in a real-time fashion for other quality-based activities that they have not done on their panel of patients or other patients that they are working with. So the idea of how are we going to do reporting is less a pull function than it's going to be a push function. We are going to push people into having to give us the good data on a real-time kind of basis so that the pull function down the road is a little bit simpler, a little bit better documented, and something that will stand up to better scrutiny. Do I know anybody currently working on doing all of this? No, I don't. I wish I did. But I think that as you look at all of the basic trends that I just talked about, there's nothing there that vendors or products in the marketplace today aren't doing, either in other industries or as generally available commercial products. And so when you kind of piece that all together and to think about how we're going to use that in the healthcare space, my personal belief is that those trends will lead us over time to a point where we have better, more timely, more accurate quality reporting. So that's my story, and I am sticking to it. So thank you.
Good morning, everyone. From my perspective as a chief nurse executive and as a chief nurse, this is my 5th rodeo. So in essence, a lot of the different things I've learned started with doing TDS screens in the early 80s, I think, for our first go live 1,000 years ago in Massachusetts. So in essence, the electronic medical record has been formulating itself and finding its way into the inpatient environment for quite a while. At UCLA, it's a pretty large scale operation. We have 4 hospitals, we have 952 inpatient beds, and we have over 250 ambulatory clinics, and we're growing. In addition to that, we have about 1.5 million outpatient annual visits, and we employ close to 4,000 nurses. So a lot of the challenges that come with looking at the electronic medical record and the patient and staff nurses or staff's experience with that centers around a very large group of people, and it's hard to keep everybody happy, to your point. So in essence, some of the different things that I found with doing this at UCLA, we did a big bang. Now, I've only been there since September, so I'm doing this based on urban legend and stories told to me. But the decision to go to Epic in 2013 was done as a big bang, and they went house-wide and system-wide with that process starting in March of 2013, and then from that point forward, June of 2013, the ambulatory launch started. So in essence, we have got effective February 2015, we did our upgrade with Epic. So in essence, we have everything at our fingertips that we're going to need to continue to craft the best electronic health record experience for staff and patients. And it's interesting from my perspective because a lot of the different details that happen now is incorporating the other things and the other technologies that people are designing and bringing to the table into the electronic medical record. For example, there are predictive modeling softwares that use a Rothman index, if you will, to measure how sick a patient is. Well, let's get that in there. Let's do predictive modeling. So in essence, what's happening, a lot of different things are lumping themselves into aspects of the electronic health record that is really challenging us as an organization about streamlining, reviewing, and organizing our thoughts about what we need from our electronic medical record. And some of the things I've learned in the course of my time as a chief nurse and as a staff nurse is you have to go back to the bedside. You have to go back to where care is delivered to understand the importance of different activities, workflow, and other processes that enhance or diminish that patient-nurse or patient-provider experience. So a lot of the different details that we've tried to focus on center around our workflow and what's available out there to enhance that. One of the other pieces that we've run into is the sheer reality of IT in healthcare right now. The last 3 places I've been, UCLA, UCI, and a land in Florida far, far away, we had an IT shortage as far as project managers and really experienced people who could help us drive the electronic medical record from a clinical perspective. And the shortage was so great at UC Irvine that what we did is the informatics team and the nursing team partnered to create their own nursing informatics group. We took 14 of our best and brightest bedside nurses and managers, and we developed them into IT experts for the go live with our inpatient nursing record. It made a huge difference in what we were able to incorporate into the clinical documentation portion of the electronic health record. And it also challenged us to look at finding ways to extract data and create data warehousing that did not require nurses or other care practitioners to mark spots or add extra hash marks or documentation to their day. And a lot of the things that that's allowed us to do in the industry itself is it's actually allowed us to look more closely at how we push information, as you were saying, how we push information to the appropriate caregiver or to the appropriate part in that patient's stay with us or clinic visit. So those are some of the different details that I've had the opportunity to participate with IT groups and the informatics teams at the different places that I've worked. The partnership between the provider and your information technology team is critical. And for a very long time, IT evolved as a separate thing. They were our documentation system. They were kind of like the pencil in our day. And today, with the changes in technology as it relates to equipment that we use at the bedside and the disks and the IT connections and the Wi-Fi associated with those things like IV pumps and heart-lung machines and all these different details, they're suddenly in the IT shop as well as in the biomedical shop. And as a nursing leader, unfortunately, it's something you have to always have in the back of your mind. How do we make sure the right people are at the table to enhance and promote the patient experience? So those are some of the details that we get into, and sometimes it requires the IT expert and the nursing expert to hold hands and drill into the data and look at it from each other's perspective. Some of the recommendations that I've found along the way as I've worked with these different groups to grow our electronic medical record center around really studying workflow and challenging ourselves not to just automate a form, which we do have a really bad habit of doing in healthcare. The other piece also is to challenge the technology companies and technology in general to do what we need you to do, or we need technology to do, not what happens to be available in the market. One of the benefits about working at UCLA and UCI is that those young people at the business schools and the IT departments and things at the university are really enhancing the capabilities of the things we can do at the bedside and at UCLA and at UCI. So that's been a real plus, but that doesn't happen everywhere. So the second thing is remain person-centric, and not only patient-centric, but staff-centric as well. So in being person-centric, you're taking the patient's true perspective on the issue at hand or the experience at hand, as well as the staff's. We have a tendency in healthcare to be very paternalistic, and I think until we understand the patient's perspective on what their needs are, much like the orthopedic guy who doesn't want to really know about the upper respiratory infection, how do we challenge ourselves to really look at what the patient's needs are and what the patient's desires are with that length of stay or with that ambulatory visit instead of ours? So that's going to be really important, incorporating what they have into that medical record as well, as far as those perspectives. How do we measure care? What are the metrics that we can pull from the back of that automated record, from the back of the electronic health record, that help us see the opportunity for predictive modeling around readmissions, mortality rates, things like that, so that nobody has to go looking for it. It comes to you. We generate a report or a dashboard where that information's housed and it gets shared at the appropriate quality or operations group or clinical group. And then finally, the predictive modeling piece is only going to continue to play a stronger role in healthcare. We're data rich a lot of times and information poor. Challenging technology to help us predict some of the outcomes of our patient populations, whether it's disease-based or injury-based. How do we start to do that in a more organized fashion so that we are ahead of the curve with that patient who's failing or that patient who's suddenly in extremis? How do we know that ahead of time? The technology is on the cusp right now, but it takes a lot of us challenging ourselves and the people we work with to make that come, that surveillance concept, getting ahead of things. And then the transitions of care is going to require that all of us hang up our current roles and look at designing a cross-continuum care model that assures that we keep patients at the forefront of what we're doing, that we value and measure their experience, but at the same time, we are understanding that the right provider at the right time with the right resources is intersecting in that patient's healthcare continuum to make a difference in their quality of life. It's all about promoting health and well-being now. We're shifting away from a disease-based medical model to more of a human-based nursing model as far as how care is delivered. And that's one of the things that we need to prey upon, is we need to really stay focused on designing that cross-continuum model with all the disciplines at the table and the patient sitting right there with us as a member of that team. Thank you.
I certainly appreciate being part of this morning, and our pathway to the next generation EMR started when I was the HMO regulator in California in the mid-90s. During that time, the department launched the DMHC's HMO Help Desk, which to my mind is all about listening to the patients to get their perspective and using that to influence how the system deals with that patient, and also use it to help drive systemic reforms, improvements. On my last day, we approved the Blue Cross of California conversion that created the California Endowment and the California Healthcare Foundation, but also approved the restricted Knox-Keene license, which is the organizational architecture for full-risk ACOs taking comprehensive responsibility for patient care in California. And the initial pain point that we're focusing on at Healthy Way is the biggest impediment to fluid integrated delivery system, and that's the Tower of Babel. Multiple systems holding patient data, multiple EMRs, multiple HIEs, multiple claim systems that don't talk to each other, maybe can't talk to each other, or don't want to talk to each other. That is getting in the way of the types of integrated fluid care that we all want to see. There's an article, cover page article today in Managed Healthcare this month, untangling the HIE mess. And once it's untangled, the opportunities are quite significant. One of the biggest concerns in healthcare is security. I mean, if you don't have data security, you have nothing. So the third generation system needs to have layers of security. HIPAA is just the baseline. HIPAA starts where you need to be concerned about security. Real security goes way beyond HIPAA. I think one of the greatest missed opportunities, or not fully tapped opportunities in healthcare, is getting the patients and the patient families off the sidelines. Active management of the care in a fully informed way. At the patient level, the patient family level, and the patient support network. I think that's a really valuable way to move the needle. And I think the biggest barrier, one of the biggest barriers to innovation is bandwidth. I mean, Karen just mentioned the strain on IT resources. It's not just IT departments that have no time. Doctors have no time, nurses have no time, patients don't have enough time, IT departments don't have enough time, and that is probably the biggest barrier to innovation. People don't have enough time to think about what should be coming because they have so much on their plate. So we're approaching this, with a few core elements of our third generation approach. One is secure, real-time pulling of patient data from multiple EMRs, HIEs, other data systems, organizing that data in the cloud the way the user wants to see it. I mean, in healthcare, one size fits one. So the information needs to be tailored to the user. So you pull it from their multiple systems, organize in the cloud, and then present it where someone is on whatever device he or she accesses the internet. We think it's very important to have a nimble mobile-first approach. It sort of starts with how the data is delivered on any mobile device, but it's much more than that. I mean, in our mind, we're not building applications or solutions around systems. The systems are the ingredients. We're building applications around users. So the systems are the sources of data that you pull from, but they don't drive what you present to users. They are, as I said, the ingredients. And one of the things we think it's important to put attention on is a very light touch. I mean, you can't consume person years of IT resources to get things done because their resources aren't available. And it's also important to put time in the development to listen to users because users are the ones that are going to be using what you have. And grassroots innovation tend to stick. Force-fed innovations, much less so. And we also think it's important to have both provider-facing applications and patient-facing applications. So, for example, in our mobile data viewer, we present clinicians with data about their patients from their patient list, but we also provide a patient look that gives the patients access to their real-time data and the ability to deliver it on the spot to a physician they present themselves to. Because the healthcare is the nexus between providers and patients, and it's important that both sides be engaged and informed. And also we think that it's important to be extremely agnostic and cloud-based. And by agnostic, we mean a series of things. First, mobile delivery agnostic. I mean, if you're talking about getting data into people's hands where they are, you need to get it to them on whatever they have in their hands. I mean, that is definitional. That's what it means to get to people data when they need it where they are. Another thing is data structure agnostic. These systems talk different languages. I mean, when I was in high school and tried to learn French, it was tough, and I wanted to learn it. Well, HL7 doesn't want to speak to FHIR, it doesn't want to speak to X12. Getting systems to talk to each other is very difficult. I'm sure many of you spent many, many years or with people around you trying to get systems to talk to each other. We think that's, we're trying to bypass that. We want to be, and we are, data structure agnostic, so we can work with any form of structured data. It's also important that the handshakes be agnostic, that the way people interact with data or how they exchange data, the handoffs of data exchange need to be whatever people are used to using or what best fits the situation. To the point Karen makes, it's not the right approach to say, here's what we have, let's make it work for you. It's, what do you need? Let us build something that works for you. That's part of that is being agnostic with respect to data exchange and data standards, and also data location. I mean, the data is not just in the four walls of your system. It's going to be the organizations you work with. It's going to be the patients with the Bluetooth-enabled devices they have. The world of data, big data is not so much about volume, but it's about sources in our mind. So it's important to be able to pluck data from multiple sources in multiple locations in real time. And I think ultimately what we're trying to accomplish with the third generation EMR is accelerating the pace of innovation by lowering the barrier to innovation, by giving the users of data the ability to say, this is what I want to see and this is how I want to see it, and then present it to them. And that's how you increase the use, that's how you increase the value of data, at least in our mind, and that's where we're headed.
Thank you, Gary.
Good morning. I'm Korey Capozza. I'm with the Children's Partnership. And my comments are going to be a little bit of a twist or turn from the other panelists because my experience and expertise is really with that patient look that Gary just mentioned and with the patient portal aspect of an electronic health record. I'm with the Children's Partnership, and we have an HIT division that's really focused on promoting use of HIT to drive coordinated child-centered care. We work mostly with minors, with children. We've had 2 pilots that we've been doing across the state, one in Ventura County, where we've looked at connecting data from the child welfare system and the county medical care system to create a more complete record of foster children in care for foster parents, as a PHR for foster parents. And then we have a second program in Sacramento for older youth in foster care. So we work with challenging populations, under-resourced populations around PHR and patient portal adoption. Prior to joining the Children's Partnership, I worked for Health Insight Utah, which is the quality improvement organization, was the Beacon program and the REC program for Utah, and was the consumer engagement director there and did a lot of work around how to advance consumer engagement and patient engagement using technology tools. So I'm going to talk a little bit today. It's sort of the complement, I think, to maybe Zan and Gary's comments. But how can you use the patient portal feature of an EHR to really drive quality as a QI tool? And the basic premise here is that if you want to improve quality, you need to figure out patient engagement. And there's 2 reasons for that. One is that most care, most important care, doesn't occur in the clinical encounter, especially with chronic disease. It's occurring out in the community and in the home with patients trying to manage things like diabetes and asthma, congestive heart failure, and so on in an ongoing way. And so figuring out how to engage that patient, get them activated and so on is really key to improving measures around chronic disease quality. And chronic disease is patient-controlled. It's the habits, behaviors that are really going to improve outcomes, especially with things like diabetes. And as we've discussed, payment programs are starting to acknowledge this, and with ACOs, value-based payment, meaningful use, and so on, are rewarding organizations that can do this well. Some intriguing and specific evidence for this, I think, comes from studies that have been coming out. There's the 2010 Kaiser study, which I think is still a little bit mystifying, but in their look at 35,000 diabetes and hypertension patients that use the patient-physician email function in the patient portal, they saw it was associated with improved HEDIS scores across the board. They speculate as to why that's the case, guessing that it was probably the continuity of care piece and the increased connectedness, the patient-physician connectedness that drove that improvement in HEDIS scores. And then a 2004 study in Colorado found that use of patient portals was associated with better treatment adherence for patients with congestive heart failure. So this can be a really nice quality tool if used correctly. So thinking about what do patient portals need to look like in the future to achieve the goals of quality improvement and quality reporting, well, one, I think, key thing is that people need to actually use them. Which sounds obvious, but that's actually a pretty hard nut to crack. As we look at organizations, they're achieving about 5% adoption of patient portals. And the really stellar ones are getting up to maybe 20%. So it's actually quite difficult. And why is that? And I think it has to do with a lot of things, which include how you integrate, how you talk about a patient portal and enrollment and so on into your workflow, which is something that was mentioned earlier, but really using front office staff, integrating it into a clinical visit. A key thing that's been found in studies is a robust endorsement by the physician. Those things are all really key in terms of getting people enrolled in a patient portal. The other thing that works really well, and this is kind of getting back to Gary's point about knowing your user, is to market the features that they actually like. And consistently across the board with the projects I've worked on in the literature, there's 4 features that really stand out for patients, and those are provider communication, so some sort of electronic communication with a provider, prescription refills, looking at labs, and scheduling. Those are all attractive pieces of a patient portal that you should really be talked about when trying to get people to sign up. And don't just send an email. It doesn't work. We've discovered that in our own pilots. You're not going to get past that 5% threshold just using that type of approach. The other piece is the usability piece and the health literacy piece. So kind of consider the tech proficiency and health literacy of the audience. For example, many visit summaries are completely unintelligible to people, so the content that you push out needs to be understandable and valuable for people to come back. And then that tailoring piece, so a more personalized tool is going to have greater use and greater adoption. Privacy and security, people are really worried about this, and it came up in our focus groups that we recently did in California, especially with the recent breaches and so on. Communicating what protections are in place for consumers is important. And I think next generation tools really need to have a way of dealing with more sensitive data, especially related to minors, permissions around that, and things like substance abuse and other pieces of data which have more nuanced privacy and security rules around them. Interoperability. We do a lot of work with children with special health care needs. And if you're a parent with a child with special health care needs, cerebral palsy, something like that, your child is seeing 3-4 specialists, primary care doc, is going to the hospital. You may be managing 5 or 6 different patient portal accounts. So some way to aggregate those disparate accounts, connect them, connect to an HIE, have mechanisms for pulling that data together into a whole patient or whole child view is going to be important. This trend in patient-generated data, wearables, apps, and so on, where patients are tracking their own data, the ability to integrate that and to understand the provenance of that data, I think is going to be really important. In a pilot that we worked on in Utah, using a home-based text message tool for diabetes self-management, we were able to see kind of real-time blood sugar readings. And previously, the physicians in that pilot were just looking at A1C, which is a longer-term marker of blood sugar control. And they found that when they looked at that more nuanced blood sugar data, they were seeing really valuable trends. For example, one patient's blood sugar was spiking every Friday night. So that patient was going out and doing something every Friday night that was causing problems for his diabetes management. So it's actually useful information to have in a clinical environment. And then finally, data control, thinking about what patients see, and this movement around open notes to let patients see more data, including physician notes, visit notes, and I think that's going to be a big trend, more transparency, and the ability for patients to correct errors when they see them, because I think patient engagement is a two-way conversation and involves some back and forth. And those were my comments. Thanks.
Thanks, Korey. And we wanted Korey to kind of bring us back to the patient at the end of this discussion. But some of the questions that I wanted to ask for those of you that are here on the panel who've had this vision of where things are going, where do you think we are today, right now, with this pressure to report quality, to pay for quality? Are we ready with the electronic health records we have today?
For the inpatient, we are being penalized or rebates held back or what have you for different hospital-acquired conditions and injuries. So we're already falling prey to the quality or the consistency of our documentation or the records we use. So in essence, that's already rolling out. It has across the hospital-acquired conditions, but now with patient experience, what was the patient's perception of their overall rating of the hospital, or would they recommend the hospital or the healthcare system to their friends and family? So we're already living that in the healthcare environment where I sit. So it is a little painful on a quarterly
And do you
basis.
feel like your EHR, though, is up to that challenge of reporting quality appropriately?
I do, because what I see is we use advisory boards to go in and weigh in on the different changes that we're making. We're about to go live with a lab product, and the amount of workflow assessment and involvement of the end user has been pretty exceptional, I think. And I think that the pre-work and the planning is going to allow us to have a very smooth transition. And I think that's the success of any of these. The key stakeholders together looking at everything before they go live, making sure they've planned out not only for the implementation, but for the what-ifs, should something go awry. So we're ready.
You're ready? Aisha, I know you have an opinion on this.
I don't think, at least for us with the community clinics, that they're ready. I think right now the clinics are, I see someone shaking their head too. I see right now the clinics, they're used to gathering their data for reporting with UDS and HIMSS. But anything beyond that, they don't really know how to use that data to empower them and to help them make better business decisions. In addition to that, a lot of the EHRs, they do have data reporting tools, but they're not robust enough to really to tell a story or to really get down to where the problems in the clinics might lie in regards to their data. I think data is, it's kind of a cheat sheet. It's like a way to really get the insight in your clinic and where you might be struggling and where your weaknesses might be. A lot of leadership in our clinics aren't even ready to hear that. When they see that they're doing poorly in a certain area with their report, they think that the report is wrong. They don't think that there's no way we're not, checking for tobacco screening with all of our patients. But if instead the clinics use that to say, we're not doing well here, what can we do to improve, and target the problem areas based on the reports that are coming out of their EHRs, they can really use that to become one of the best healthcare providers. But right now, I think the clinics are they're just so used to what's happening tomorrow instead of what's happening 5 years from now.
I would just add to that, for fear of offending anybody, that the most important player in American healthcare is the federal government, and we're already doing a ton of reporting that gets in the hands of the federal government. Who knows how good it really is or isn't at the end of the day? That's a whole nother question for a whole nother hour. And yet that information is becoming the basis for federal policy, federal decision-making, at a minimum impacting the Medicare, Medicaid, and other segments of the population that fall under government jurisdiction, which by definition tends to trickle over to the public arena. So we're being impacted by it today, whether we want to admit it or not, in terms of what's going on the reporting side. And it's hard to see a scenario. I was chatting with Gary over in the speaker's room. It'll be interesting to see what comes out of the election. Again, forgetting political persuasion, but you've got Bernie Sanders now openly talking about doing something that's a federal healthcare one payer kind of program that seems to be gaining in some level of popularity in various segments of the marketplace. So, I mean, the idea of what we do, what the industry does from a reporting standpoint, and getting it right and being sure that the data is correct and that the data gets interpreted correctly is critical for federal health policy, which impacts all of us, either because we work in the industry or because we're patients ultimately. So.
And on one federal policy point, CMS is moving forward with what they call their Next Generation ACO initiative, which is moving towards full risk. I mean, that's where they want to go. It's a lot easier to budget. If the incentive is the right way, the data is the right way, you tend sometimes to get better outcomes on a full risk basis. That's the theory. I think it's been proven out in some real cases in California with the full risk integrated delivery systems that we have here. But that's where the federal government wants to go. And the Next Generation ACO initiative that they announced earlier this month is part of that step.
Absolutely. Questions from the audience? We've got a couple microphones out there. Folks have any questions? I have plenty, so. Yeah, there's a gentleman back here.
you raise your hand again, please?
There you go.
Thank you.
Hey, good morning. My name is Eric Barnett from Slalom Consulting. Just a quick question around patient-reported information into records, and you touched on it a bit, but can you talk about the challenges of using that information and making their own information more available? And the second question, really to Karen and Zan, you talked about our physicians and nurses. Are we training them the same way, or are we training them differently given the way they have to use technology today?
Sure, so I'll touch on the issue of patient-generated data. Well, right now, I think what's happening is those of us with Fitbits and so on are using the information ourselves and not discussing it with physicians. And so ideally, if there's a way to integrate this into patient portal and possibly even the EHR, it can be actually part of ongoing case management and chronic disease management, a conversation with the physician saying, wow, you've been inactive you've gained 50 pounds. Over this period of time, what's going on in your life? Your blood sugar is out of control. What's happening to you every Friday night where you're having these big spikes that are leading to poorly controlled diabetes. So I think that's sort of the direction it needs to go. How you do that, in my prior role in Utah, we worked on a proof of concept to figure out how to move information from a patient's glucometer in the home into Microsoft Health Vault, and then into a separate tool, which then moved it into primary care physicians' EHR. And from there, we tried to send it to a specialist using direct. So it was so complicated, we couldn't get any patient to figure this out. The data was all garbled. So how you do it, I don't know yet, but I think there's huge promise there, and it's something to figure out as we look to the future.
One of the things that we have is a mobile photo uploader that allows pictures to be taken on a smartphone and uploaded into an EMR. What that is, to make that happen, we have to establish a secure bi-directional communication between a mobile device and a host data system. I mean, that is the Internet of Things. So right now, the mobile device is a camera on a smartphone. The next iteration will be a mobile survey. What's your pulse ox and what's your weight level? Or it will be Bluetooth-enabled monitoring devices that feed into your phone and then are appended into your EMR. And that's how you aggregate that kind of personalized data and begin to take further advantage of the patient's perspective.
That's great. There was another question here. Oh, Zan, did you want to follow up?
Go ahead. Next question.
Yeah.
Hi, my question is to Korey, Capozza. I was wondering if there's electronic data collected from child mental health care, specifically between children between the age of 12 and 17, the leading cause of death is suicide. And I've been trying to get statistics and data on that, and I haven't seen any data collected from that. I haven't seen specific data collected from that. Is that collected in the EHRs?
I actually don't know the answer to that. I do know that in the pilot that we worked on in Ventura County around at-risk youth, getting the behavioral health data was really a challenge, and also pulling in medical data for children over 12 was a challenge because there's very nuanced rules around what you can actually display to parents. So it gets very complicated very quickly. But to your specific question, I'm sorry, I don't know the answer.
I think we're going to take one more question back here. Oh, I'm sorry. Go ahead. You were first. Go ahead.
Sorry, I'll be brief. I'm just curious, and to anyone in the panel, I think there was an inference or an implied need for data governance to support analytics and reporting. And I'm curious if any of you have had any experience specifically operationalizing that within, a large health system or a large provider network.
Go ahead.
I had the opportunity to do that. The chief information officer, when he came into my last experience, we actually overhauled our entire operational structure as it related to the addressing the use of information in the EMR. And we created a governance structure that went across both the academic and the hospital/clinic environment, with members of senior leadership and members from the academic community, the dean, things like that. And then we trickled that down, creating different groups that oversaw aspects of inpatient, ambulatory, things like that, and outlined how money would be spent, how things would be prioritized, and how things would be triaged in the event that something popped up unexpectedly. And it had a very stabilizing effect on the organization, because prior to that, it was, IT was like a black box that we just kept putting money into. And this allowed us the opportunity to really start to have questions and good, healthy conversation about where our priorities should be and what can we afford and how do we implement what we need.
I would also say one of the interesting things about data governance is, sooner feel like you're done with it than you get to do it all over again. It's kind of like painting the bridge across the river, and as soon as you get done, you got to go back and start all over again. So it's if you have an informal data governance process or no data governance process, it's a long, circuitous, tough, difficult process. And the first time you do it, you're probably going to get less than 100% of the way there, like so many things in life. But it's ultimately you have to have it if you want to be able to have effective, consistent data, both in terms of supporting day-to-day operations and, of course, your reporting coming out of that.
Great. I think data governance in all of this is a great place to end, and I know we've poached into your lunchtime. So first, if you join me in thanking the panelists, thank you very much. This was fantastic.